Hello and welcome. This is an overview of the cardiac cycle in a heart with normal physiology. The diagram you see on your screen is the standard diagram used in cardiac physiology called the Wiggers diagram, named after Dr. Carl Wiggers, and this diagram basically explains it all. So I'm going to take you through it, and then hopefully you'll go through it yourself and understand it well. So I've also included the jugular venous pressure waveform. It's one of my favorite physical exam findings, and one of the most difficult as well. The components of the diagram are the following. First, we have the aortic pressure curve, which is our arterial waveform, and these are what we see on the cardiac monitor when using an arterial line. The dicrotic notch corresponds to the closure of the aortic valve. Next, we have our LV pressure curve, the pressure inside the ventricle. Look at the variation in this curve. In diastole, it's about 10 millimeters of mercury, but during contraction, that pressure goes all the way up to about 120 in the normal adult. And that's obviously important because the left ventricle is how we get blood to our bodies. Next, we have the atrial pressure curve. The atria work at much lower pressures than the ventricles. And here's the LV volume curve. This shows us the filling and emptying of the left ventricle. And here's our EKG representing electrical conduction. And importantly, the events on the EKG curve occur slightly before the events on the other curves, because in order to have contractions, you have to have conduction first, and that's what we see on the EKG. And last, we have our jugular venous pressure curve, and this curve corresponds to the pulsations on our patient's neck exams. All right, so let's go through the entire cardiac cycle, and I like to start here with the opening of the mitral and tricuspid valves. And let's always be asking ourselves why things are happening. So why have the mitral and tricuspid valves opened? So it's because the atrial pressures have exceeded the ventricular pressures. And as long as that's the case, the valves are going to stay open. So next we have diastole. So ventricular filling is occurring here, and we can see this on our red ventricular volume line as it gradually increases. Now towards the end of diastole, we have the P wave on the EKG, and that represents atrial contraction. That gives us our atrial kick, and that accounts for about 15 to 20% of our preload, i.e. our left ventricular end diastolic volume. And this is the end of diastole. And now, by looking at the EKG, you'll see that conduction is traveling through the ventricles, and this is going to cause them to contract, and this begins the phase of the cardiac cycle known as isovolumic contraction. And what this does is it causes the pressures in the ventricles to quickly exceed that of the atria. And that's going to cause the mitral valve to close. And that's our S1. So now we see that all the valves are closed for a brief moment. And at this time, pressure is building up very fast in the ventricle. It can't push blood backwards because the mitral valve is closed. And it can't push blood forward because the aortic valve has not opened yet. I want to point out that the arrows are pointing to a notch on the atrial pressure curve, and that's all due to pressure pushing backwards on the mitral and tricuspid valves. And there's no regurgitation there, but the pressure pushing against the valves is so high that it causes atrial pressures to rise. And on the JVP waveform, this is the C wave, which we'll show you later. So isovolumic contraction, breaking this down, we have isovolumic, meaning that the volume stays the same, and that's demonstrated here on the red curve, the ventricular volume curve, and the LV pressure is contracting, and that's building up pressure, as we can see on our LV pressure curve. And that pressure is going to quickly build up in the ventricle, and eventually it's going to overcome the aortic pressure, which is essentially the patient's diastolic pressure. So in a normal person, that's about 80. And at that point, we see the aortic valve open. But the LV pressure doesn't stop at 80, right? It goes to about 120 in a normal person, and it drives the systolic blood pressure. The ventricles eventually relax, as demonstrated by a sudden drop in pressure on the LV curve, but the aortic pressure will stay elevated, right? So all that volume in the arteries is maintaining an elevated blood pressure. Remember, the arteries don't contract, but they have enough volume in them that it's maintaining the pressure. The LV pressure drops rapidly, and the aortic pressure will again exceed the LV pressure, causing the aortic valve to close. And at that exact moment, when the aortic valve closes, that's when you get your dicrotic notch. And the dicrotic notch is basically a rebound effect because as all that blood goes into the aorta, that artery stretches to try to accommodate all that blood, which will go wherever it can. So it'll try to go backwards, but as the aortic valve closes, it rebounds forward. And if you look closely, you can see that the aortic notch begins at the exact moment of aortic valve closure. And as we talk about the ventricle emptying, one of the hardest concepts to grasp is this. As the LV empties, the atria are filling, right? So the filling of the atria during systole is demonstrated on the graph by a rise in our atrial pressure curve. So once the aortic valve is closed, we begin the phase of the cardiac cycle known as isovolumic relaxation. Isovolumic, so no change in ventricular volume, and we can see that on our LV volume curve. The LV pressure continues to relax, and it relaxes to the point where the atrial pressure, once again, will be higher in pressure, and you know what happens next. So that's right, the mitral valve opens as well as the tricuspid valve on the right side of the heart. So that's the normal cardiac cycle. At a later time, we'll go through the changes that occur on these curves with various pathologies. For now, it would be wise to try and draw these out on your own. So finally, I did want to briefly talk about the jugular venous pressure curve, because if you understand the physiology of the curve, you can see it on your patient's neck exam. So normal jugular venous pulse. So the A represents a positive wave due to contraction of the right atrium. The C is a positive deflection due to bulging of the tricuspid valve towards the atria at the onset of ventricular contraction. Next, we have the X descent. This is a negative deflection due to atrial relaxation. And V is a positive deflection, and that's due to the filling of the right atrium against a closed tricuspid valve that occurs during ventricular contraction. And then you have Y, which is a negative deflection, and that's due to the emptying of the right atrium upon ventricular relaxation. Another thing to keep in mind is that oftentimes you won't have an A wave because the patient will be in atrial fibrillation. So the atria do not contract, therefore you do not get the A wave. So that's it. Next time we'll go over some pathophysiology and how that can be applied to the Wiggers diagram. So hope to see you then. For now, so long and goodbye.